Hello friends, today I'll be talking to you about a very important topic, that is mitral stenosis. So first of all, if I asked you one question, if you have seen 100 confirmed cases of rheumatic heart disease in pediatric age group, you have seen 100 confirmed cases of RAD in pediatric age group. In what percentage of cases you will see mitral stenosis? You get 30 seconds to think and answer this question. Rather, you note down this answer in your copy if you are carrying a copy. Otherwise, you can just make up a mind. But speak out from your mouth so that you know what I spoke and what is my sure answer. In what percentage of cases you will see mitral stenosis? Okay, I hope you have written the answer. The answer is almost 0%. Almost 0%. I'm sure it must be a big shock for all of you. If not all of you, at least most of you. Now, why this is the answer? For that, we got to learn the basic concept. Without basic concepts, you will never understand what the problem is, what are the main symptoms. All these you learn only when you know the basic concept. So the basic concept goes like this. This is the heart, and this is the mitral valve. A normal mitral valve area is 4 to 6 square centimeter. Average is 5 square centimeter. Okay, so I'll be taking 5 as the average. Well, now when the area goes to 2.5 square centimeter, then start the symptom. Point to be noted that area goes down to almost 50%. From 5 to 2.5, symptoms start appearing. This is the important point to be remembered. Now, what is the main symptom? Dyspnea on exertion is the main symptom. This is the second carry home message for you. Dyspnea on exertion. Why this is the symptom? Let's learn more basic concept. So this basic concept is when area has gone down to 2.5, there is difficulty in flow of blood from LA to LV. So there is obstruction to flow from left atria to left ventricle. So blood start accumulating in the left atrium. So normal LA pressure is 4 to 8 millimeter of mercury. But as the obstruction is there, blood will accumulate in the left atrium. LA pressure start rising. So friends, the most characteristic feature of mitral stenosis is increase LA pressure. This is the most characteristic feature. So when LA pressure goes to around 18 to 20 millimeter of mercury, then blood start entering into the pulmonary veins. Remember, LA is a thin walled chamber. It cannot accumulate much blood. So blood start entering the pulmonary vein, and there occurs pulmonary venous hypertension. After that, pulmonary capillaries are congested, and there occur pulmonary capillary hypertension. And still later on, pulmonary arterial hypertension occurs. So simple, it's all back pressure, increased LA pressure, venous pressure, capillary pressure, and arterial pressure. So this is a sequence, but this is the most characteristic finding. This is the question for you. Now, as the capillaries are getting congested, so that's why the main symptom is dyspnea on exertion. As capillaries are congested, that can also lead to hemoptysis. Now, one more thing. As the blood is getting accumulated in the left atrium, the LA size increases. LA size increases. And just behind the LA is recurrent laryngeal nerve, left recurrent laryngeal nerve. This nerve gets pressed. The patient does start getting hoarseness of voice. This is known as Ortner syndrome. Ortner syndrome occurs due to pressure on the left recurrent laryngeal nerve. And just behind LA goes esophagus also. The esophagus can get compressed. So this can lead to dysphagia. Well, as LA is getting enlarged, the LA wall become more and more thin. They predispose to atrial fibrillation. So once the atrial fibrillation occurs, the atrial discharge rate goes very, very high. So that lead to increased ventricle rate. So this also lead to increase in ventricle rate. And that lead to palpitation. So now patients start complaining of palpitation. So palpitation occurs when ventricle rate is very, very high due to atrial fibrillation. And as the blood when the atrial fibrillation occurs, the atria are not contracting, and that lead to stasis of blood in the atria. That lead to thrombus formation in the atria, which can go into embolic phenomena, which can lead to thromboembolism. Now, one more question. That this embolism can occur in both systemic circulation as well as pulmonary circulation. Now you are definitely going to ask me how it can lead to pulmonary embolism. Again, basic concept. This is the atria. Of course, the problem is of mitral stenosis. But remember, when atrial fibrillation occurs not only of the left atrium, but also of the right atrium. Both atria are fibrillating. That leads to stasis of blood, both in LA and RA. So the clot formation can occur in both LA and RA. From this, it will go to systemic circulation. From here, it will go to pulmonary circulation. Is clear to all of you? What is going to happen in these patients? So now let's see what are the causes of mitral stenosis. And I have asked you the question, in what percentage of cases of pediatric age group you see mitral stenosis? And my answer was it is almost 0%. Why? So let's see what are the causes of MS, rheumatic heart disease, RAD. Friend, for all practical purposes, MS occur only in RSD. It means if in a patient MS is present, it is surest feature that patient is suffering from rheumatic heart disease. It is very rare to be congenital. Very rare to be congenital. And it very rarely occurs in condition like methotrexate therapy, some calcification of the or annular calcification, etc., etc. But they are extremely rare causes. You read Harrison, he gave 5-6 causes, but they are all extremely rare causes. So for all practical purposes, the MS occur only in rheumatic heart disease. It's clear to you? Now, more basic concept before I give answer why MS is only 0%. Basic concept. Basic concept. Now, common age of rheumatic fever is 5 to 15 years is the common age of rheumatic fever. Suppose a patient develops rheumatic fever at the age of 10 years. Now, it needs about 10, 15, 20 more years to develop stenosis. That means he will develop stenosis at the age of 25 to 30 years of age. Stenosis never occurs overnight. So, patient develop MS in the middle age or somewhere in the 20s, late 20s or 30s. And that's why. And pediatric age group is the about 12 years we talk about. That's why. Since it's not congenital and it cannot develop before 10, 15, 20 years. That's why MS is usually not seen in pediatric age group. Very rarely it can be seen below 18 years, but it's very uncommon. This is known as juvenile mitral stenosis. Okay, so now you are clear about it, why MS is not seen in the pediatric age group. Friends, many of you will be going for MD pediatric exam. Yes, you will go. You are very intelligent. So, in MD pediatric exam, there is always a case of rheumatic heart disease. Surely you will also get a case of RAT. In that case, in your patient, MS will not be there. Normal, the common lesion are MS, MR, AR, AS. MS will not be there. Okay? During the discussion, examiner will say, I'm listening the murmur of MS. Then you have to say very respectfully, sir, MS doesn't occur in pediatric age group. Then he'll say why and how. Then you have to give the explanation, what I have told you just now. And examiner will be very happy to know you know the basic concept. So friends, 25% of the discount I'm giving you, I'm saying this in a very lighter way, that in your case, MS will not be there, right? So we learned about the basic concept, why dyspnea occurs, dyspneic exertion occurs, why hemoptysis occur in MS, and the only cause of MS is rheumatic heart disease for all practical purposes. Now we examine the patient. Now on examination, what we get? You get loud S1. S1 is loud. Upward arrow means loud S1. Opening snap is there. If you are listening opening snap, it means the valve is pliable. The valve is pliable. It is not calcified. It's not calcified. Okay, valve is pliable. But once the valve is calcified, then the opening snap disappear and S1 become soft. Okay, S1 becomes soft. Then in MS, third sound is never heard. Again I repeat, in pure mitral stenosis, third sound is never there. Why? Again, basic concept. Basic concept. Here is the heart, mitral valve. So during diastole, in early diastole, rapidly blood enter both the ventricles. Around 70% of the blood come from atria to ventricle in early diastole, so-called rapid filling phase of myocardium. And during this, in a normal heart, in JVP, you get wide descent. In a normal heart, normally there is no sound is there. But if a sound has to come, it is third sound. So in nutshell, third sound and wide descent both occur in early diastole in the rapid filling phase. So I can say very comfortably, wide descent correspond to third heart sound. Now, since mitral stenosis is there, rapid filling phase is never prominent, because rapidly, no way, rapidly blood can enter the ventricle, left ventricle. That's why you never get third sound in mitral stenosis. It's clear to you? Well, so what we learned, third sound is never heard. What we get? You get mid-diastolic murmur with pre-systolic accentuation, And this occurs due to atrial contraction, which occurs in the later phase of the diastole, late phase. So more because of pressure of atria, more and more blood flows more rapidly into the ventricle, left ventricle, and that lead to pre-systolic accentuation. And so now this is due to atrial contraction. So obviously, if a MS patient develop atrial fibrillation, this pre-systolic accentuation will disappear. Now you get tapping apex beat. You get JVP is raised, and you get prominent, and JVP is usually raised, but this is secondary to due to pulmonary arterial hypertension. So you may start getting prominent A wave in JVP. What else you get? You get left parasternal heave. You get left parasternal heave. Why? Because in these patients, right ventricle hypertrophy occurs again due to after pulmonary arterial hypertension. Patients start developing right ventricle hypertrophy, and that comes as left parasternal heave. So friend, in nutshell, what we are getting is you are getting a loud S1, you are getting opening snap, and if pulmonary arterial hypertension has occurred, you may get loud P2 also. You get tapping apex beat, left parasternal heave, prominent A wave, and you get mid-diastolic murmur with pre-systolic accentuation you get. Okay? So this is about the symptom. The main symptom is dyspnea on exertion, and the main thing is in pediatric age group it is not seen. So in the next lecture tomorrow, I'll be talking to you about investigation, management, surgical and medical treatment about this thing. From day after tomorrow, I'm starting, now exams are coming. Lot of students are asking about last minute revision points. which I am sending to all of you. And they are very popular. The huge demand is there. Then what from day after tomorrow, I'll be starting last minute revision point discussion series. Discussion series. Friend, you attend this discussion. Your almost 50% question of medicine in AIMS, PGI or NEET, they will be directly coming from these last minute revision point. So in that way, I can say in a lighter way, in a very cool way, that I am leaking the paper to you, because all these points, question will be coming from what discussion I'll be doing. This discussion I'm starting from day after tomorrow. In the evening, the details you will get in your Facebook only. Don't miss, and you can solve more than a 50% question of medicine from this last minute revision point. And of course, I don't need to tell you, all these last minute revision points are given in each of our book of 2017 after each chapter of each subject. Okay, I hope you are having these books. Otherwise, you can go to our website and you can purchase this book on heavy discount also. See you tomorrow evening, same time, 4:15. I'll continue with the part 2 of mitral stenosis, and day after tomorrow I'll be starting about last minute revision point series. Thank you very much for watching this video. My previous videos are there in YouTube. You can very well see those videos also. And if you have any suggestion, don't hesitate to send the message via messenger. Thank you very much once again.